No? Oh, sorry. So, quick run through. We've heard so much about this, so I won't give you the details about this, but a very quick rundown between the two sides. Either you're transplant eligible or not, or you go down the non-transplant route. Non-transplant route up until now was fairly straightforward. ATG plus cyclosporin, eltrombopag was considered in the refractory setting. You had androgens and all sorts of other developmental therapies. Best done in consultation with a center which has expertise in managing aplastic anemia and bone marrow failure. And I won't talk much about the transplant options. And this is how the algorithm looked. These numbers, age numbers, are fairly arbitrary. I'm not an ageist. Again, you had this option down this side where you could have a transplant. And if you didn't, then you had horse ATG cyclosporin, and hopefully you were amongst the 2/3 who showed response and hopefully kept that response, and you wouldn't have to think more about it. But if you lost response or relapsed, then you had the options of going down the route of eltrombopag and unrelated donor transplant and all sorts of other therapies, including danazol. This is to prove we're not ageists, and just an enticing thought to see, perhaps we can come to this at the very end of it. What would be more preferable if you had to choose between an unrelated donor transplant and immunosuppressive treatment in somebody who's, let's say, 50 or 55 or 60. But I think before we go down the route of treating patients, it's very important to answer these three questions. And these are paramount questions, absolutely essential questions to be answered, which is this aplastic anemia constitutional? And I kid you not, this is sometimes made painfully unaware to you. You can be painfully unaware to this, and it's brought to your attention. We recently had a 16-year-old boy. He came with acute fulminant liver failure, and he had a liver transplant. He was directly put on a liver transplant list, had a liver transplant, and 2 months down the line, he started to drop his blood counts. We thought initially it's immunosuppression. He could have some features of some portal hypertension and all that. But lo and behold, we did a bone marrow, and he was a patient who was evolving with aplastic anemia. So these things happen all the time. So it's very, very important. It happens to the best of us. We need to have a mind that's very open to it. Please consider whether this aplastic anemia, is it constitutional? It's important that we exclude other conditions that can mimic aplastic anemia, including hypoplastic MDS. We had this wonderful interesting conversation amongst ourselves as to how it can mimic and how it can present and what our thresholds would be. And finally, if we had ways that could help us predict, we've had so much of talk about artificial intelligence these days as well. If we could predict this patient is going to respond to ATG cyclosporin plus eltrombopag, no eltrombopag, would it alter our plan of treatment? This is personalized medicine. If we could do that, that'd be an absolute godsend. So I think these three questions are very, very important. They're paramount in being answered before we go down the route of seeing our patients and talking to them about their treatment options. And this is what I meant. I won't talk much about histology, but it's important that there is a specialist review. I cannot emphasize this strongly enough. It's important that we have included iron stains. It's important to have ascertained the nature of any lymphoid clones that are present in a hypocellular empty bone marrow with fat spaces. Again, people have been caught out with acute lymphoblastic leukemia in a subleukemic form. It's important to have cytogenetics. Cytogenetics SNP karyotyping results do take time, sometimes a couple of weeks, and you may not have the option of waiting, but it's important to have at least carried out a thorough baseline review before initiating treatment. And finally, again, we need to have next generation sequencing for the myeloid and bone marrow failure panels. So this is the kind of improvement that speakers before me have talked about. This has all happened over a period of 50 years. We are blessed in aplastic anemia world because the kind of advances that we have seen in aplastic anemia for a disease that is so rare, with an incidence of 2 to 4, no matter where you go, between 2 to 5 per million, to have such beautiful studies done, such collaborative efforts between centers, to get such meaningful results, such high value, high impact journal publications, including NEJM, time after time. It's absolutely amazing, both on the transplant side as well as uh, on the immunosuppression side of things. And this is a quick snapshot of why we come down to immunosuppression treatment and what we choose and how we choose. This is just aplastic anemia is a quintessential autoimmune disorder. You have everything that can go wrong in the autoimmune setup going wrong. Here you have, let's start with the hematopoietic stem cell. And this cursor is moving now. Yeah, this is the hematopoietic stem cell over here. You have these oligoclonal cytotoxic T lymphocytes which are attacking this hematopoietic stem cell. And why they are attacking this hematopoietic stem cell? And that's because quite a few things are going wrong over here. You have the naive T regulatory cell population, which is going up, and the memory-like Treg population, which are supposed to exert an inhibitory effect on these cytotoxic T lymphocytes, not doing their job. You have this massive skewing of the Th1, Th17 expansion, which results in this inflammatory environment, massively inflammatory environment with the interferon gamma and TNF alpha floating around. They all entice these cytotoxic T lymphocytes to attack the hematopoietic stem cell. And you have the fast ligand being activated directly as well. So quite a few things happening in this quintessential autoimmune disorder. If it's a pure autoimmune disorder, this is what it would look like. And this has resulted in why we have developed the autoimmune treatments in aplastic anemia. But come to think of it, horse ATG cyclosporin is not the best of choices for immunosuppression. You have better drugs. You have much better drugs at T cell depletion, at suppressing the T cell responses in aplastic anemia. So this peculiar combination of horse ATG working better than Campath or high dose cyclophosphamide is just intriguing, actually. I don't know what the answer for that is, but it's just an intriguing thought. And this is what I meant by collaborative effort and the kind of studies that have happened in a disease that is so rare over the last 50 years. When you start counting from the late 1970s, starting off with androgens, the initial German trial, which showed that ATG cyclosporin is extremely efficacious. We've shown that GCSF does not really add much. We've tried other immunosuppression agents, sirolimus and MMF instead of cyclosporin. We have conclusively proven that rabbit ATG is not as good as horse ATG. That is not in doubt. I mean, I do accept that there are cultural preferences, there are access issues about ATG in different parts of the world, but let's not doubt the efficacy of the results that have been done. And finally, we've had the addition of the thrombomimetic agents. And there are other things that are happening, which, if time permitting, we can just have a look at. So just a quick snapshot. If we are giving horse ATG cyclosporin, we expect 70% of our patients to show response. 30 of our patients will not show response. Those patients who don't show response, again, it's very important to make sure that we are not missing an obvious diagnosis. Complete responses are seen only in 10% of our patients. Cyclosporin dependency is seen in a quarter of our patients at 6 months. Infection remains the most common cause of death, and the incidence of MDS, solid tumors, and hemolytic PNH is as below. This is a beautiful study from Sweden, because there are very few longitudinal studies that have been done that have followed patients for 10, 15 years, or there are very few publications about it. And this one study in particular shows that from 2000 to 2011, for a decent cohort of 257 patients, stem cell transplants, when followed up for 15 years, is giving you excellent results. Immunosuppressive treatment is halfway down, and cyclosporin alone is not as effective. Again, you come and look at the age cohort of these patients over here, you find that people who are between the age of 19 to 39 do extremely well. In fact, better than people of the pediatric age group, perhaps because pediatric age group patients have, I'm not sure why, they must have perhaps some may have constitutional bone marrow failure or other system issues. And then finally, you have age-related decline. People in the 40 to 59, and finally, people below the age of above the age of 60 don't do as well. And this is what I meant by horse ATG and rabbit ATG. There isn't any doubt about it. I go to some meetings where people again keep talking about as if there is an issue or there is a doubt about this question which has not been answered completely. No, it has been, please. This is a very, very good study which has been done, and it very conclusively shows that horse ATG is significantly superior to rabbit ATG. Rabbit ATG is associated with a significantly increased risk of infections and also associated death. And finally, coming to the last question about people who relapse. Again, ATG is very effective. Nearly a third of patients will show response to another combination or another round of ATG, no matter which combination you look at. So ATG per se is a very effective treatment in aplastic anemia, even in the relapse setting when you're limited by choices. And this is what we come to the era of personalized medicine. We don't have the absolute immune signature and the genetic signature over here, but we do know that patients, on the whole, the younger you are, the better you do. Responses are generally better in patients who have severe aplastic anemia as compared to very severe aplastic anemia. Reticulocyte count and lymphocyte count again help in predicting responses. Trisomy 8 is generally good, with a slight caveat that you ought to have a PNH clone with it. Trisomy 8 is good only when you have a PNH clone with it. Trisomy 8 is not so good if you don't have a PNH clone associated with it. Del13q is always good. Monosomy 7, no matter which myeloid disorder you're talking about, is always bad news. The benign mutations, PGA and BCOR, are good. The epigenetic mutations never as good. DNMT3 is not so bad if it is as part of a chip clone, which means that the clone size is less than 10%. It's not as bad. And using high sensitivity flow cytometry, if you find a significant PNH clone, it predicts for good response to immunosuppressive treatment. And subsequently, our center at King's has shown that Tregs can help predict response. Two very good papers again from Austin, and they've shown that this is essentially what happens. We've had a few talks about this through the day. Recovering stem cell, as it expands, feels the pressure, acquires mutations. Some of these mutations can be epigenetic mutations, and this predicts your risk for MDS. On the other hand, you can just smolder along with near normal counts or slightly less than that as a partial response, and you can still continue to do very well. And this is what you would expect after immunosuppressive treatment. This shows the favorable mutations in aplastic anemia and the not so favorable mutations in aplastic anemia. And the question being, are the patients who evolve with the not so good mutations in aplastic anemia should be considered for transplant or not? So these are all of these issues and burning questions that come up to us by the time we've reached to this story with L-thrombopagan. Now we come to the story of triple therapy. Yeah, I think this is again just showing how these two separate out very early on if you have severe aplastic anemia compared to very severe aplastic anemia. I'll just move on with this. This is the story about Tregs, a deep phenotyping using 8-color flow cytometry analysis have shown that if you separate out the Treg population as being FOXP3 high or low, you have these two population of Tregs over here, A and B, and this B population, which is FOXP3 high, predicts for a better response. If you have more of these B cells, you're likely to show a response to immunosuppressive treatment. And the attempt obviously would be to see if we can harness the beneficial effects of these Tregs for therapeutic treatments in aplastic anemia. And there'll be studies at King's. All of these options remain on the plate, where you can consider IL-2, adding IL-2, using autologous Tregs, allogeneic Tregs are all under consideration as clinical trials in aplastic anemia. I'll skip through this bits and come to the main question. So we've heard about L-Trombopag and what it can do. It started with this study, which was an incidental finding. And this was in the context of patients who had relapsed refractory disease. These were people who had received some form of immunosuppression treatment. Some had received 1 or 2 rounds of treatment, and incidentally, accidentally, however you call it, fortuitously, L-Trombopag was selected, was given to a cohort of patients, and lo and behold, we have nearly 40% of patients who showed response. These were responses that were not just restricted to the megakaryocytic lineage, but rather often showed bilineage and also trilineage responses. Interestingly, these responses were sustained even after discontinuation of treatment. And here you see how the bone marrow starts to repopulate itself on initiation of treatment, essentially showing normal hematopoiesis at the end of 6 months. So this led to this, of course, alongside comes the slight worrying concern about L-Trombopag and clonal evolution, and particularly with monosomy 7. And it's something that is been a consistent concern for some of the studies that have been performed. And it is a question that still needs to be answered, whether the clinical benefits that we get with L-Trombopag, are they good enough to override the clonal evolution and transformation to MDS-AML that you might see? Does it actually translate to an overall improvement in survival in the long run? This was the study, again, very well conducted study. We had 3 cohorts built up. The cohort 1 starting on day 14, cohort 2 starting from day 14 to 3 months, and cohort 3 starting from day 1 itself. Very well conducted study. Let's come directly to the numbers over here. I think you've seen this slide very often. I think the cohort 3 is what we are interested in, which was starting L-Trombopag on day 1 itself. And the best case scenario, seeing overall responses of 95% with complete responses of 59%. Amazing results, eye-opening results. It's not very often you see results that separate out like this. So amazing. This really shook us up. And this has prompted another study in Europe, which was the RACE study, identical study. We had to do it in the European cohort. And alongside there was supplementary bits that we always wanted to look for, including clonal evolution, next generation sequencing, Treg population, telomere length. And that has now been reported, and this has been published in January in NEJM. Again, very well conducted study. And the nutshell is that you see better responses with L-Trombopag added to HOS-ATG and cyclosporin, and these responses are sustained. And this also translates to better overall responses, not as much as what we have seen with the study from NIH, but this is a 3-month endpoint that has been analyzed, and going forward, we will need more data. So this is the response that we have seen, and this study over here shows there's a 68% response at 3 months. Both of the groups were matched. One had 101, one had 96 patients. There's a significant p-value to complete response, which is 22% at 3 months. And similarly, there's a significant p-value to overall responses, which is 68% at 3 months. This is how the curves separate out in terms of first response and complete responses, both with significant p-values. Event-free survival is a little too early to answer, but it looks like there is a slight gap opening up towards the end between both the groups. And this obviously needs more follow-up. So in short, we're saying that we are seeing better responses. We are seeing a complete response in 1/4 of patients with severe aplastic anemia who are treated with triple therapy compared to only 10% of patients who receive standard treatment. Again, we're saying 68% showing at least a partial response or more compared to 41%. So this 41% looks a little lower than what you would have normally expected, but this is perhaps sometimes, as we've seen, that there is a cumulative effect. As you accumulate time, perhaps you do a response analysis at 7 months or 8 months, you might start to see these curves going up further. Anyways, the time point was scheduled for 6 months, so this is what we have for analysis. It still remains a very significant p-value. And the rates of infections were no higher between both groups, and we didn't see much of liver complications either, especially in the L-Trombopag arm of the study. Now, do we have any other evidence besides these two large studies? There's been a study in China, which again looks at intensive immunosuppressive treatment with L-Trombopag. There's some minor subtle, not subtle actually, there are some significant changes to the study plan, and hence the results have to be interpreted in light of how they have conducted the study, which is that they used rabbit ATG instead of horse ATG because they still have a doubt in their minds whether horse ATG is better than rabbit ATG. They've used a continuous dose of L-Trombopag at a steady dose of 75 milligrams from day 1 itself to 6 months. And this is a non-randomized study. So there are some differences in this study that is being conducted. Good numbers of patients are conducted over a 7-year period. But because of the differences, it's not truly speaking apple for apple comparisons. And their study shows that you see complete responses again of 21.9% and overall responses of 59.4%, which is a significant p-value in the L-Trombopag arm. The benefit persists at 6 months, both on univariate and multivariate analysis in the L-Trombopag arm. But this wanes off by the time we reach 12 months, such that the triple cohort just starts to fall behind the standard cohort on both aspects. So I'm not sure what's happened between 6 months and 12 months, or rather, perhaps people who just had the horse ATG cyclosporin caught up with the other arm and almost looked like as if they were overtaking it. Liver derangement was significantly lower at 6% compared to about 18% seen in the study from NIH. But we have to remember that this is the population from the Far East, where pharmacodynamic studies have shown that they need lower doses. I'm not sure whether it includes the Chinese population or not, perhaps it's the Japanese population, but they do take smaller doses of L-Trombopag. So I think if I had to look at the pros of this study, whether I would go for triple therapy if someone had severe aplastic anemia who's 55 years old, I would say that yes, I'm bought over to the idea that there is definitely better complete responses. There is a better chance of having overall responses. This treatment is very safely tolerated. And interestingly enough, I think it's perhaps easier to access L-Trombopag to ATG sometimes than just accessing ATG in different parts of the world. And with the generic branch of the L-Trombopag now becoming available, cost might also be an issue. So there are quite a few pros, but don't want to sweep anything under the carpet. There are some questions that need to be answered, which is that we need more longitudinal data. The longitudinal data about overall survival comes, and I'm sure that will be data that will come from both the NIH as well as the EBMT studies. We need to factor in the risk of clonal evolution and bone marrow fibrosis. Clever as we are, we rely on meta-analysis of randomized controlled clinical trials, or rather we should, but somehow the last patient you've treated is what influences often your decisions. The last patient I treated developed very significant bone marrow fibrosis and complex cytogenetics on L-Trombopag. And it shouldn't be this way, but I'm just mentioning that these things do happen. But we need we need to factor in the risks of clonal evolution and bone marrow fibrosis. The question about continuation of L-thrombopag at 6 months as part of the study is fine, but for how long after that? And there is a risk of clonal evolution to MDS and AML, even with immunosuppressive treatment, and perhaps even without immunosuppressive treatment, I think. But there is a slightly increased risk when you add in immunosuppressive treatment, and furthermore, if you add in L-thrombopag. And the extra risk that you're going to get with monosomy 7, MDS AML transformed, resulting in excess deaths. Will it take away from the benefits that you will get from having achieved better responses, better complete responses, earlier responses? We don't know. This is where overall survival data is very important. And it brings us, these days, we've heard such interesting talks. In fact, we've gone 2 steps further where we're talking about haploidentical and mismatched transplants, because that is the kind of success we're seeing with allogeneic stem cell transplants. And not often we have matched siblings available. With the kind of work that we're doing in this field of unrelated donor stem cell transplant, is it now the time to bite and say that, look, we're doing this so good, why take this risk of treatment, risk of failure, risk of relapse, risk of clonal evolution, and you'll think about transplant after 4 years. Maybe if you're 25, you don't have to worry about it. But if you're 64, what's the question? What would you prefer? Would you have triple treatment, or would you have an unrelated donor stem cell transplant from a fully matched donor? I don't know. So I think at this point in time, I concur with your view. My scales are tilting because there's no doubt about the complete responses and the better responses you're seeing up front. And perhaps the longitudinal data is too short to comment about clonal evolution. Maybe these are patients who are anyways due to have clonal evolution, even if they just had horse ATG and cyclosporin. I think there is some merit in saying that there should be consideration for triple therapy, cost not being a factor, access not being a factor. Those are my thoughts. Thank you so much. And